Welcome. My name is Barb Miller. I'm an endocrine surgeon in the Division of Surgical Oncology at The Ohio State University in the James Cancer Hospital and Solove Research Institute. I'm the co-director of Ohio State's Comprehensive Adrenal Program, along with Dr. Lawrence Kirschner, one of our endocrinologists. Together, as part of Adrenal Awareness Month, we hope you find the material that follows to be valuable. Whether you're a patient, a family member or significant other, an advocate, clinician, researcher, or other interested party. In the series of lectures that follows, we'll provide broad overviews of the evaluation and management of adrenal cancer, including additional content covering genetics, radiation therapy, survivorship, and current research in the field. Each lecture ranges from 5 to 15 minutes. Afterwards, join us for a panel discussion, including experts from our comprehensive adrenal program at the James and members of ACC Warriors, a group advocating for patients and progress in the field. At the end, a list of resources is provided, and additional information can be found on our website at www.cancer.osu.edu.
Hello, my name is Lawrence Kirschner, and I'm an endocrinologist at The Ohio State University James Comprehensive Cancer Center and co-director of our Comprehensive Adrenal Program. I'm going to be talking to you today about the evaluation of adrenal masses. Before I start, let's talk a little bit about the adrenal glands themselves so you know what I'm talking about. This picture shows the location of the adrenal glands, which sit on top of the kidneys towards the back of the abdomen. What is an adrenal mass? So this is any abnormal growth located in the adrenal gland that disrupts the normal gland's appearance. On the left part of the slide, you can see a CAT scan with a number of body parts labeled, showing the adrenal gland in a blue circle. The adrenal gland is a small gland and has an appearance of an upside-down V. On the right side of the slide, you see a similar CAT scan, but now the blue circle shows a mass in the adrenal gland, which looks like it's about 2 centimeters and round, and similar in density to other contents of the abdomen. So how do we evaluate adrenal masses? Masses like this present in 2 ways, and the appropriate evaluation depends on the presentation. So first of all, mass may be found during the workup for a suspected secretory adrenal syndrome, for example, during evaluation of Cushing syndrome. Secondly, an adrenal mass may present as an incidental finding detected during the evaluation done for something else. So if we think it's a suspected secretory mass, what might be the culprits? Well, the adrenal gland really makes 4 different steroids. It makes cortisol, which is a steroid hormone, aldosterone, a blood pressure hormone, the sex steroids, estrogen and testosterone and their precursors, as well as catecholamines such as adrenaline. I do want to point out that sometimes adrenal tumors secrete multiple hormones, so we may do a variety of tests if appropriate. Sometimes these combinations are more suggestive that a tumor may be a cancer, but sometimes they're not. I do want to mention that pheochromocytomas are different from the other types of tumors in that they generally only secrete those catecholamines or adrenaline hormones. Cushing syndrome is a syndrome that is caused by excess cortisol production. The symptoms that suggest this are abdominal weight gain, diabetes, high blood pressure, as shown in the picture on the right side in the stick figure. The findings that suggest Cushing's a little bit more specifically than the first group I mentioned include things like bruising, especially for people that are not on blood thinners or aspirin or other drugs like that, plethora, or the reddening of the face, weakness, particularly involving the proximal muscles such as the shoulders and the hips, and those reddish, purplish stretch marks as shown in the purple marks on the stick figure. However, because these symptoms may be nonspecific, it is important that we're selective in who we're testing, because things like obesity, diabetes, and high blood pressure are very common in the general population. So how do we test someone that we think may have Cushing syndrome? Well, there's 3 tests that we typically begin with. Often, if testing are positive, we'll do 2 or 3 of them. The first test is a 1 milligram overnight dexamethasone suppression test. In this case, a person is giving 1 milligram of dexamethasone to take at 11 o'clock at night at home and goes into their local lab to get blood drawn around 8 in the morning to measure cortisol. We expect that if you take a synthetic steroid like dexamethasone, your own levels of steroid should be low. If they're not low, that's abnormal. The second test we use is a 24-hour urine collection of cortisol, and the third test is a measurement of midnight salivary cortisol to look for the rhythm in cortisol secretion. Cortisol secretion is normally quite low at night, so an elevated nighttime salivary measurement is abnormal. After the diagnosis of Cushing syndrome is made, we often need other testing to determine the origin of the hormone. Typically, the first test we get is ACTH, which is normally made in the pituitary, but is sometimes made in other cancers or tumors and stimulates the adrenal glands to make cortisol. In cortisol-producing tumors, the ACTH levels will be low. Sometimes we use high-dose dexamethasone testing to determine if it's a pituitary source of ACTH or another type of tumor. We also will typically image, including the pituitary gland, if ACTH is measurable, and or a CT scan of the adrenal glands if ACTH is low. I'm next going to turn to hyperaldosteronism. Aldosterone is an adrenal blood pressure hormone, and it causes high blood pressure, low potassium, and often accompanied by leg swelling. The test for this is relatively simple in that we just measure blood levels of aldosterone and a related hormone renin. If the aldosterone is high and the renin is low, giving an elevated ratio, this suggests a diagnosis. Many people need confirmatory testing, which may be more involved. It may typically include a saline suppression test, which is an IV test typically done in an outpatient clinic, or a salt loading test, which can be done at home. These aldosterone-producing tumors can be quite small and may not be well seen on a CAT scan or an MRI, which is why sometimes we proceed to a more invasive test called an adrenal vein sampling test. I'm next going to turn to sex steroid-producing tumors, which are generally pretty uncommon except for adrenal cancers. Androgen-producing tumors, or male hormone-producing tumors, such as those that make testosterone, may be difficult to detect in men. However, in women, they can cause facial and body hair, coarsening the voice, and other symptoms suggesting masculinization. Conversely, estrogen-producing tumors in men may cause a feminization phenotype. In women, estrogen-producing tumors typically disrupt menstrual cycles in women of reproductive age, or can cause re-estrogenization in postmenopausal women. Blood testing in these cases will almost always find the abnormal hormones, and imaging of the adrenal glands should show a tumor. Lastly, I'm going to talk about pheochromocytomas. These are adrenaline-producing tumors, or what we call catecholamines, that produce this fight or flight response. Clinically, people present with high blood pressure, which can be either episodic or sustained, sweating, heart palpitations, headaches, and other symptoms that go along with that fight or flight reflex. Testing typically can be done by blood testing for a compound called metanephrine, or by 24-hour urine testing for catecholamines and metanephrines. These tests can be affected by many medications, so additional testing may be needed, or the test may need to be interpreted carefully. Again, tumors that produce clinical symptoms are easily seen on a CAT scan or an MRI scan of the adrenal glands. I do want to mention that adrenal cancers secrete hormones in about 60% of the time, which means that 40% of these will not present as a secretory syndrome. These cancers may produce multiple hormones, as I mentioned previously. So we'll often measure a panel of hormones, and sometimes we can do a large panel either by blood testing or urine testing, and this may help with the diagnosis of a cancer versus the identification of a benign tumor. I want to spend the last few minutes talking about incidental adrenal masses, which is the other way that we find these types of tumors. These are masses that are discovered inadvertently in the course of testing for something else. This excludes patients that are undergoing workup for another type of cancer, because people that have other types of cancer, such as breast cancer, colon cancer, and so on, if they're found to have an adrenal nodule, it's most likely going to be a metastatic disease. Adrenal incidentalomas are common, and population and autopsy studies suggest that they're present in about 5% of the population. They seem to be present equally in males and females, although they're more often detected in women. The incidence of these tumors does go up in age, that younger individuals are much less likely to have one, but as we age, the incidence goes up at a rate of approximately 1% per decade. When we find an incidentaloma, we have two questions to ask. One, is it hormonally active? And two, is it cancer? If it's not secreting hormones and we don't think it's cancer, then typically we don't intervene or take them out. So what about this question about is it hormonally active? There is very good evidence that all patients that have one of these adrenal incidental detected tumors should be tested for Cushing syndrome and pheochromocytomas. Additionally, people that have high blood pressure should be tested for the hyperaldosteronism. The testing for this is the same one that I just described previously, so I'm not going to go through it again. I want to mention that if a test comes back normal, these are very, very good at excluding secretory activity. If the tests are abnormal, it may indicate the need for additional testing. What about that second question? Is it cancer? We know that adrenal cancer is a very rare disease, literally about 1 per million, which means that these people are out there, but they're not common. The risk that an adrenal mass is a cancer is somewhat size dependent, and you can see on this table that small tumors are very unlikely to become cancers, whereas those that are greater than 6 centimeters is about a 25% chance. Because of this, adrenal nodules that are greater than 6 centimeters are almost always removed, although some guidelines actually recommend routinely taking out slightly smaller tumors in the 4 to 6 centimeter range. When we look at these adrenal nodules, dedicated fine-cut CAT scan is usually the best way to do the imaging. If a non-contrast CT scan shows a density of 10 Hounsfield units, or HUs, this basically indicates that it is a benign tumor. And we can get the same information out of a chemical shift MRI, although there's usually not a lot of reason to get an MRI if a person has already had a CAT scan. Sometimes we do an Adrenal Protocol Ct, which is a pre-contrast scan, a post-contrast scan, and then a delayed scan, so 3 scans in one. In this case, benign tumors demonstrate rapid washout of the contrast. Any tumor that's not identified as benign is considered indeterminate, meaning that there's a possibility of cancer. Other imaging features may make a cancer more or less likely. I want to remind everyone that the median size of adrenal cancer at the time it's found is usually about 11 centimeters. So these are typically very large tumors. In terms of following these tumors, the guidelines from different organizations vary somewhat and are affected by size and appearance of the nodule. For those small nodules, follow-up may not be needed if they're hormonally inactive. For medium-sized nodules, annual follow-up for a few years is probably reasonable, and anything larger than 4 centimeters, we definitely want to follow up, probably within 6 to 12 months, depending on the appearance. In each of these cases, if the nodules are growing, it may indicate the need for reevaluation or surgical removal. Thank you for your attention. I hope you found this talk informative. Hello, my name is Lawrence Kirchner, and I'm a professor of medicine in the Division of Endocrinology, Diabetes, and Metabolism at The Ohio State University James Comprehensive Cancer Center. I'm also the co-director of our comprehensive adrenal program. I'm going to give you a short talk today about the medications that we use to control adrenal hormone excess. Before I get to that, though, I do want to spend a minute talking about the fact that surgery is typically the first line of treatment for secretory adrenal tumors. However, the reason that we have these medications is that there may be specific reasons why medical therapy is needed. For example, there may be tumors that either cannot or should not be removed, but that are making hormones which need to be treated. Secondly, sometimes patients are medically unstable for surgery, in which case we use medical therapy for the short term until we can get them prepared for surgical intervention. Then thirdly, there are sometimes diseases that involve both adrenal glands. In this case, we have to balance the benefits of removing both glands and having the patient on steroid replacement therapy for the rest of their life versus what we can do with medical therapy. And that is a good discussion for each person to have with their medical provider. I'm going to start off by talking about drugs that we use to treat Cushing syndrome or cortisol excess. This slide shows many of the symptoms associated with Cushing syndrome, and the image in the upper right corner of the slide shows a quick stick figure of what these individuals might look like. We actually have a number of very good therapies for medical treatment of Cushing syndrome, and I'm going to go through them in different categories. So first of all, there are a number of drugs that function as steroidogenesis inhibitors. In other words, they block the ability of the adrenal glands to make hormones. The most commonly used one is a drug called ketoconazole, which is dosed 2 to 3 times a day and usually works fairly quickly, although it has a number of side effects, including stomach upset, and can cause significant liver damage. Because of this, we typically do not recommend it, and the FDA has not approved it for the use of Cushing syndrome patients. The second drug we use is a drug called Mifocryston, which also blocks steroid production, but in a different way. This also works quickly and has a similar set of side effects, including the GI upset. However, because of the way this works, it can divert some of those hormones and cause excess male hormone production, or androgens, leading to abnormal hair growth. Mitotine is another drug that blocks steroid productions. It is, for many years, the only drug approved for adrenal cancer. It works by both killing off adrenal cells, both tumor cells and normal cells, and blocking hormone production. This drug has a number of significant side effects, including the fact that it has a slow onset of action and levels need to build up in the body before it is effective. The side effects are typically of a GI nature, including nausea, vomiting, or diarrhea, and it can also cause a variety of neurologic symptoms, such as numbness, tingling, dizziness, and so on. People that are taking Mitotine need to be monitored closely by someone that is familiar with the drug. Lastly, etomidate is another type of steroid synthesis inhibitor, although it is normally used as an anesthetic and only works through the IV mechanism. So patients that are receiving this are typically hospitalized in an intensive care unit. There are 2 medications that work in the case of pituitary-directed Cushing, pituitary-caused Cushing's due to an ACTH-producing tumor. Pasireotide is typically given as a monthly injection and works to suppress hormone production from the pituitary gland, which in turn suppresses the adrenal gland. This is most successful when levels of elevated cortisol are not that high. Cabergoline works similarly and is not particularly effective, but sometimes it does work, so maybe worth a try. At the bottom of the slide, I talk about Mifocryston, which is a glucocorticoid receptor antagonist. Mifocryston works by blocking the ability of cortisol or other glucocorticoids to bind to the receptors and cause effects. In this way, it does not reduce hormone levels, it just prevents them from acting. Because levels don't change, it may be difficult to determine what is the proper dose of Mifocryston, and we have to use clinical criteria to make this decision. It is worth noting that Mifocryston also has other effects in blocking another hormone receptor called the progesterone receptor, so it causes abortions in pregnant ladies. And because of this, it has received a lot of bad press. However, it is very effective for treating a Cushing syndrome. Over the past 2 years, we've seen the approval of 2 new drugs for Cushing syndrome, which also work by inhibiting the synthesis of the hormones. One drug is called Osilodrostat, or Isturisa, and it was approved in March of 2020. Like the first ones I mentioned, it is rapid and highly effective. It is similar in its effects to metyrapone, so that it may cause hirsutism. It also is a very potent drug, so may cause levels of cortisol to drop quickly, and patients taking this need to be monitored. L-Ketaconazole, or Relicorlin, is the same drug as regular ketoconazole, although it's not a mixture of the right-handed and the left-handed forms of the drug. Because it's only composed of the more active part, it seems to be more effective on a milligram basis. However, the side effects seem to be very similar as the combination ketoconazole, although may be less frequent. I do want to mention that there is a new drug which is currently in trials called Relicorlin, which works similar to Mifocryston, but does not have the effect at the other receptor, the progesterone receptor. So it seems to be much more specific for Cushing syndrome. Stay tuned to see how that goes. I'm going to talk next about treatments for hyperaldosteronism, which is really a disease that's characterized by high blood pressure, low potassium, and swelling. There are 2 drugs that have been long used for this condition. The first of these, which has been around the longest, is called Spironolactone. And this, like the Mifocryston for the cortisol receptor, spironolactone blocks the interaction of aldosterone with its receptor. So it typically does not bring the levels down, but also can be quite effective, although it may take some titration up to 200 to 300 milligrams per day, divided 2 to 3 times to be effective. Because aldosterone tends to bring their potassium levels down, people treated with spironolactone may have their potassium levels go up. There's also a significant effect in men where it can cause a condition called gynecomastia, which is swelling of the chest or breast area, in about 25%. Because of the way spironolactone acts, it may also cause some leg swelling, although this typically goes away for people that remain on the drug. The second drug we have is called a Plarenone, and this works very similarly as it has the same mechanism of action from spironolactone. It has the same adverse effects on potassium and swelling, but it does not seem to cause the chest or breast swelling because it does not interact with the biochemical mechanism that causes that. It's also much more expensive. So typically people will be started on spironolactone, but if they don't tolerate it, we'll switch to a Plarenone. The effectiveness is similar for both drugs. I also want to mention that there's a new drug that is being developed, which is called CIN-107. This actually is a synthesis inhibitor, but these trials are just beginning now, so we don't really know if that will work. Stay tuned. I want to spend a few minutes talking about inhibitors of sex steroids, so androgens are the male hormones and estrogens, the female hormones. These drugs have been well developed and are much more common, and there are many more options because they're used in prostate or breast cancer. To treat androgen excess, we can use drugs that block the ability of the testosterone to bind to its receptor, and these drugs include spironolactone. Yes, it's the same drug I just mentioned, and this is why it causes that gynecomastia in males. But there are other options too, including ones that are much more commonly used for prostate cancer, such as enzalutamide, bicalutamide, and other drugs like that. There are also drugs which block the ability of testosterone to be converted to its active form, and these drugs are shown on the slide, including finasteride, dutasteride, abiraterone, and others like that. Estrogens can be treated the same way as androgens can, and these drugs really come in two classes. Those drugs that block the ability of estrogen to bind to the estrogen receptor, and these include drugs like tamoxifen, raloxifene, clomiphene, and fulvestrant, although fulvestrant also has other activities. And the other class of drug are those that inhibit the ability of the body to make estrogen, including anastrozole, letrozole, exemestane, testolactane, and so on. These are well characterized, and many oncologists are familiar with them because of use in the other cancers, as I mentioned. Lastly, I want to talk about drugs that we use to prevent hormonal symptoms in patients who have pheochromocytoma, or those adrenaline-secreting tumors. The symptoms of these tumors include high blood pressure, sweating, palpitations, headaches, and so on. And any patient that's going to get surgery for a pheochromocytoma should be treated for at least 2 weeks prior to reduce the chance of surgical complications. People whose tumors cannot be removed can be on these drugs for the long run. So the alpha blocker, or drug that we use to treat these, that has been around the longest, is a drug called phenoxybenzamine or dibenzoline. This blocks the interaction of these catecholamine hormones with their receptor and will prevent the high blood pressure, the sweating, and so forth. Because these hormones cause high blood pressure, when we block them, it can cause low blood pressure, especially on rising in the morning in a condition called orthostasis. It can also cause the pulse rate to go up, or what's called reflex tachycardia. The other drugs that we use in the second row are other types of alpha blockers, which are generally better tolerated than phenoxybenzamine itself. And these drugs, Cardura, Minipress, Hytrin, you can see the generic names there, are used for other types of blood pressure, and these are more selective blockers at the receptor. These cause similar side effects and can also be associated with swelling of the legs, although this is not quite as common. I do want to mention Labadolol, which is an older drug that blocks both the alpha and beta receptors, and because of this, it can be used for pheochromocytomas. However, more complications have been reported with this drug, so it is generally not recommended by experts in the field, including us. Lastly, phantolamine is a drug of the same class. It's an alpha blocker, but it's an intravenous drug that can be used during surgery for these emergencies, and it's typically only used in the acute setting. In closing, all of these drugs to treat the different hormone excesses are generally quite effective for control of the symptoms, although they don't treat the tumors themselves. Most of these drugs are not widely used in clinical practice, even by many endocrinologists, so they generally should be used by experienced practitioners that know what to look at and how to dose them. The drugs can be used in combinations, although there are many drug-drug interactions, so this has to be done carefully. Again, thank you for your attention, and I hope this was informative.
In this segment, we'll talk about surgical decision-making for patients diagnosed with a mass concerning for or known to have adrenal cancer. And by adrenal cancer, we're talking about adrenocortical carcinoma rather than tumors which have metastasized to or traveled to the adrenal gland from another site in the body. Although the surgical technique for resection of malignant pheochromocytoma is similar, pheochromocytomas are a different type of tumor originating from a different cell type and are managed differently. And our discussion will not include this other type of rare adrenal malignancy. When we talk about surgery for adrenal cancer, there are many things surgeons think about. To clarify up front, anyone undergoing surgery for an adrenal mass that cannot be proven to be benign ahead of surgery by various imaging studies and/or urine steroid analysis should be treated intraoperatively as if it is a cancer until proven otherwise by examination of the tumor by a pathologist after surgery. This is an extremely important concept and one you should discuss with your surgeon in advance of surgery, as the way the operation is performed for a known or possible adrenal cancer is quite different than performing surgery for a benign or non-cancerous tumor. When we're planning surgery for ACC, surgeons often ask themselves three questions. Should I take it out? How do I take it out? And how much do I take out? These questions get to the ability of a patient to tolerate an operation. What kind of other medical issues do they have, such as heart disease? How severely debilitated are they from their Cushing syndrome and excess cortisol? Is it technically resectable or not? Is there evidence of metastatic disease that would indicate to them not to remove it? The next question becomes, how do I take it out? As there are at least 12 different ways to take out the adrenal glands. In general, a traditional open approach with a larger incision is recommended rather than a minimally invasive approach. Finally, the question of how much do I take out? Obviously, we want to remove the entire adrenal gland and tumor. But beyond that, this is where the operation we do for suspected or known adrenal cancers differs from those with non-cancerous disease processes. This also enters into the decision about operating on patients who initially present to their doctors with distant metastatic disease, where tumor cells have traveled through the bloodstream or lymphatic system to other sites in the body, most commonly the lung, liver, and bone. We need to determine if we're going to try and remove these sites of disease, if we technically can remove these other sites of disease, or perhaps should a different approach to treatment be pursued. Before anyone obtains an opinion about surgery for adrenal cancer, it's important to find the right surgeon, one that is experienced in the evaluation, management, and surgery of adrenal cancer. We know from studies done over the past 2 decades that most adrenal surgery, whether done for cancers or even non-cancers, is done by surgeons performing very few adrenalectomies per year. We also know that there is a relationship between patient outcomes and surgeon volume of adrenalectomy. And because adrenal cancer is rare, most of that evidence is for patients undergoing adrenal surgery for benign or non-cancerous reasons. You'll note that the number of cases where we see a sort of cutoff associated with fewer complications is 6. And frankly, 6 adrenal surgeries is not very many per year in the grand scheme of things. And surgery for adrenal cancer is done differently compared to the way most surgeons remove benign tumors. So when adrenal cancer is a possibility, looking for a surgeon who does a lot of benign adrenal surgery and is also experienced in removing adrenal cancers in the proper way with good outcomes is important. The good thing is that these types of surgeons do exist at widely recognized centers of excellence for adrenal disorders. The website of the American Association of Endocrine Surgeons is also a good place to look, as they have a surgeon finder tool. Surgeons are thoroughly trained to understand and be able to predict the ability of a patient to tolerate surgery. This varies from patient to patient based on their prior medical history, surgical history, expected operation to be performed, need for removal of additional organs beyond the adrenal glands, such as a kidney, part of the liver, or other organs, and the effects of any hormone excess on the body. There are also tools such as risk calculators that have been developed by various institutions and the American College of Surgeons to assist in this assessment. Your surgeon will be the best judge of this. Sometimes the preoperative testing will also involve the input of a cardiologist or heart doctor and the anesthesia team to understand risk for complications, including death during or after surgery, although death is very rare during surgery. For those with hormone excess, there are medications that can help reverse the effects of hormone excess, and these are listed on the right side of the screen. Your surgeon and endocrinologist will work together to determine who may benefit from these medications in advance of surgery. There are multiple ways to take out the adrenal gland. An open approach where an incision is made on the abdomen is the gold standard. Minimally invasive techniques remain controversial, and patients should understand there are many questions that remain. The data in the literature about different surgical approaches is difficult to interpret, as the methodology used to perform many of the studies is compromised by what we call selection bias and other things. The most important things to seek when looking for a surgeon to remove a known or possible adrenal cancer is to find one with actual experience removing adrenal cancers and good outcomes. Because adrenal cancer is rare, there are few surgeons who have actually removed adrenal cancers. Of those who do, often it's incidental, and few have extensive knowledge of the disease process and tumor biology. Surgery for adrenal cancer is quite different from surgery from benign tumors. So just because a surgeon says they remove a lot of adrenal tumors doesn't mean they have removed any adrenal cancers. If they've removed adrenal cancers, you want to know what the short and long-term outcomes are in terms of complete resection of the tumors with negative margins, penetration of the outer surface of the tumor during surgery, and disease recurrence in the abdomen, as these things all indicate the quality of removal of the tumor. Regardless of the surgical approach, there are critical technical steps that need to be performed. In both benign and malignant tumors, it is extremely important that the surgeon not dissect into the tumor itself. As opposed to surgery for those with benign adrenal tumors, the entire fat pad surrounding the adrenal gland should be removed together with the adrenal gland and tumor, as surgeons cannot visualize microscopic extension of the tumor into the surrounding fat in many cases. This is not part of the standard operation done by the overwhelming number of surgeons removing benign tumors. There is no need to do that for benign tumors. The pictures shown here show how an adrenal cancer on the right side should be removed. This set of images shows the tissue we want to resect around the left adrenal gland. It is also important that tumor invading other nearby organs also be removed. Sometimes a portion of an organ can be removed, and other times the entire organ needs removed. This situation most often involves the liver, kidney, pancreas, and spleen. Leaving tumor behind is not associated with good outcomes, and if it's suspected that tumor will be left behind based on preoperative imaging, a treatment plan other than surgery up front will often be recommended to determine if the tumor size can be decreased to facilitate a later complete resection of the tumor. Sometimes blood vessels may be invaded by tumor, or tumor cells may extend into the inside of blood vessels. This situation can also be handled during surgery, but requires more preoperative planning and may involve additional surgical teams, such as vascular surgeons or cardiac surgeons. The final consideration during surgery is to determine if any lymph nodes need to be removed, as tumor can travel to other sites in the body through the lymph nodes and the lymphatic system. I was fortunate to lead a group of over 20 physicians and surgeons from around the country with expertise in adrenal cancer, including endocrine surgeons, surgical oncologists, a urologist, an endocrinologist, and a pathologist, to develop the first set of recommendations dedicated to defining the technical steps that should be carried out during surgery for adrenal cancer. This third volume of the American College of Surgeons Operative Standards in Cancer Surgery is coming out in the fall of 2022. After surgery, and assuming an open approach, patients usually spend several days to a week in the hospital, depending on the extent of surgery. Pain may be controlled with an epidural catheter, some other type of regional anesthetic block, or a patient-controlled anesthesia pain pump. The need for a surgical drain is uncommon, but may be placed, and patients resume eating when bowel function returns after surgery. For those with cortisol-secreting tumors and overt Cushing syndrome, replacement steroids are started. Patients are usually seen back in the office for a postoperative visit within 1 to 2 weeks after discharge from the hospital. Now let's talk about surgery for adrenal cancer recurrence. While we would all like it to be easy, it's much more like a murky swamp with lots of things that come up out of nowhere and try to get you. We know certain things about adrenal cancer that help us predict outcomes, overall survival, and who will have a higher risk of recurrence. The items listed in the box on the right help us with these predictions. When we think about a reoperation in someone who has recurrent adrenal cancer in some site in the body, we have to understand where and how much. Are there other sites in the body? If there is one or two sites that are resectable, will other sites pop up soon after surgery that will make that surgery quickly irrelevant? Undergoing any surgery requires a significant period for recovery. That recovery period is also a time when other systemic therapies or medications may not be able to be used to allow the body to heal or fight additional adrenal cancer. If complications occur, especially in those who are higher risk, like those with cortisol excess, additional treatment may be further delayed. There are a lot of nuances to making decisions about reoperation for tumor recurrence. Some of the things we consider include the quality of the initial surgery. If there was tumor spillage, there is often additional recurrence in the abdomen soon after a reoperation. We look at certain features from the pathology of the initial tumor removed, such as tumor grade. A high-grade tumor, or one that has traveled into the bloodstream or lymphatic channels, has a higher chance of early recurrence. That doesn't mean we don't reoperate on some patients, but it does mean we choose very carefully to whom we offer an operation. We spend quite a bit of time thinking about quality of life when considering a reoperation too. Over the past 2 decades, we found that those who have an interval from initial surgery to time of first recurrence greater than 1 year and who had negative margins, meaning the surgeon was able to get around the entire tumor, have the best chance for a good outcome after reoperation. However, we also have learned that recurrence is very common and often occurs in the same organ where we just removed some of it, especially when it comes to the liver and lungs. And that's why over time we have moved to opting for less invasive treatments to control small areas of tumor when possible. For these, we can use radiation treatment, radiofrequency ablation, cryoablation, and other treatments to try to control disease rather than putting patients through multiple operations. So when we're considering reoperation, we have to consider many things. It's a balancing act of pros and cons in understanding what the expected disease course will be. Consideration of quality of life and what the patient and their family value most or are willing to tolerate is key to shared decision-making. And all of these decisions are made in what is usually a very uncertain situation. Each decision is made in an individualized fashion and customized to the patient and their particular tumor characteristics. So in summary, there are surgeons' experience in treating patients with adrenal cancer. Surgery for adrenal cancer is different than surgery for benign adrenal disease. For those who experience a recurrence of their adrenal cancer, treatment is individualized to the patient, and surgery is one of multiple treatment options.
Hello, everyone. My name is Mifocryston. I'm an assistant professor in the Division of Medical Oncology. It is my pleasure to talk to you today about systemic treatment options for advanced adrenocortical tumors. I have no conflicts to disclose for this meeting. When do we use systemic treatments in ACC? We recommend that patients receive systemic treatments when their cancer can no longer be treated with local measures, such as radiation and surgery. The most commonly used systemic treatments available today are Mitotine and a combination chemotherapy regimen known as EDP. Mitotine is concentrated in the mitochondria, which are the powerhouses of the cell, and it works by disturbing the energy production in tumor cells. We assess the effectiveness of a therapy by measuring an entity known as the objective response rate, which is nothing but the percentage of patients who experience a greater than 30% shrinkage in the tumors with any particular treatment. Mitotine has an objective response rate of 20% as a single agent, and it's worth noting that the efficacy of Mitotine depends on the blood plasma levels achieved. Specifically, values greater than 14 milligrams are associated with a response rate of up to 69%. The FORMAC trial studied the combination of Mitotine plus EDP chemotherapy in 151 patients. EDP stands for a combination etoposide, doxorubicin, and cisplatin. The response rate achieved was 23%. In the second line, for patients who have progressed on EDP chemotherapy, another agent known as streptozotocin is an available option. In the FORMAC trial, a response rate of 9% was seen in the group of patients who received streptozotocin in combination with Mitotine. However, chemotherapies are not without side effects. Close to 58% of patients who received EDP chemotherapy had serious adverse events, compared to 42% of patients on streptozotocin. The most commonly seen side effects are low blood counts, infections, and cardiovascular complications. Moving on, today we have a newer class of treatments that are known as multi-receptor tyrosine kinase inhibitors, also known as targeted treatments. These medications inhibit the function of certain proteins in the tumor that can cause tumors to grow and grow new blood vessels. Specifically, we talk about two treatments, Levatinib and Capoxantene, which have evidence of efficacy in ACC. Beginning with Capoxantene. This is a targeted treatment that was studied in a 16-patient case series and was shown to have a response rate of 19%. 94% of these patients had received prior treatments with Mitotine, and 10 out of 16 patients had received at least 3 prior therapies in addition to Mitotine. This is an impressive result in a group of very heavily pre-treated patients. Subsequently, there are 2 single-center trials of cabozantinib in advanced ACC patients that are recruiting in the US and Germany with an aim to accrue 18 and 37 patients, respectively. The second targeted treatment of interest is lenvatinib. This was studied in a single-center retrospective study of patients who were treated with lenvatinib or cabozantinib. A response rate of 25%, including 1 patient who received lenvatinib achieving a durable response of close to 2 years, was experienced. Again, 6 of these patients had received at least 2 prior lines of therapy, which is a noteworthy result in another cohort of heavily pre-treated patients. The third class of treatments that has excited our interest in ACC is immunotherapy. Immunotherapies work by targeting proteins that the tumors use to hide themselves from the body's immune system. These treatments allow the immune system, therefore, to recognize the tumors, and in turn allows the immune system to attack the tumors. 2 of these proteins against which we have immunotherapies available today are PD-1 and CTLA-4. Avelumab is an immunotherapy against PD-L1. This was studied in a subset of 50 patients, 74% of whom had gotten at least 2 prior lines of treatment. The response rate achieved was 6%, with 42% achieving stable disease. Another study was that of a combination of ipilimumab and immunotherapy against CTLA-4 in combination with nivolumab, which is an immunotherapy against the PD-1 protein. This was studied in a trial in 16 patients with ACC, and 1 of these patients, or 6% of the cohort, had a response, and 44% had stable disease. Pembrolizumab is an immunotherapy against PD-1 protein that was studied in a trial of 16 patients who had also received at least 1 prior line of systemic treatment. The response rate in this study was 14%. In a larger study of 39 patients who were treated with pembrolizumab, the response rate was close to 23%. This brings us to the question, what is the efficacy of combining immunotherapy with targeted treatments? A retrospective review was performed of 8 patients who were treated with a combination of lenvatinib and pembrolizumab. The response rate was seen to be as high as 25%, and the disease stability was seen in another 12% of patients. Of note, 6 of these patients had already progressed on prior immunotherapy, and 5 of them had progressed on prior targeted treatments, which is a noteworthy response. In summary, Mitotine, chemotherapy, targeted therapies, and immunotherapy all have a role to play in the treatment of advanced ACCs. Combinations of targeted therapies with immunotherapies today hold the greatest promise for our patients who have developed resistance to traditional chemotherapies. Our team at Ohio State is currently working on studies of this combination to provide our patients with a novel treatment option with the hope of achieving better outcomes. So do watch this space. Thank you for your time.
In this portion of the conference, we will be reviewing the drug Mitotine, which is a treatment option for adrenal cancer. There are no conflicts of interest, commercial support, or joint provider for this program. During this discussion, you will learn all aspects of Mitotine treatment, Mitotine management, side effects, monitoring, and dosing. Mitotine is an oral drug that is given to patients to treat adrenal cancer. It is the only drug approved specifically for the treatment of adrenal cancer. The brand name is called Lizodrin. Typically, Mitotine will not be started until after your surgery because your physician will need to use the pathology report to help determine if you are a candidate for this medication. Determination for starting Mitotine is based off a patient's tumor characteristics, the stage of the tumor, and evidence of any metastasis. Mitotine works on adrenal cells in 2 different ways. First, it prevents normal cortisol production from the adrenal cells, causing decreased cortisol levels. Second, it destroys adrenal cells, both normal and cancerous cells. There are some potential drug interactions with Mitotine. Typically, Mitotine can decrease the effect of certain medications. Mitotine can interact with several blood thinners, such as Coumadin, Eliquis, and Xarelto. However, Pradaxa and Savaysa are okay to continue to take. Also, cholesterol medications called statins can have an interaction with Mitotine, but Pravastatin and Crestor are okay to continue to take. In addition, the class of blood pressure medications called calcium channel blockers can interact with Mitotine. If you are on any of these medications listed, your doctor will likely need to change to another approved medicine. Please make sure your physician is aware of all the medications you are currently taking. Your Mitotine level will be tested by blood every 1 to 3 months while you are taking it, and the dose will be adjusted depending on the result. The goal Mitotine level is between 14 and 20. Toxic levels can occur with the blood levels of greater than 20. This means you are at a greater risk for side effects if the level reaches above 20. If a level becomes too high, your Mitotine dose will be reduced. However, it is important to know that because the Mitotine is stored in fat tissue, it can take a long time to wash out of the body when Mitotine is stopped or the dose is reduced. Mitotine can affect the function of normal adrenal tissue. It can affect the thyroid gland, liver, and testes as well. It can cause a few side effects. It is important to know that not everyone will experience these symptoms. Typically, the symptoms are dose dependent, which means the higher dose of Mitotine you are on, the more likely you will develop side effects. It is important to inform your physician if you experience any of these symptoms that are listed. Nausea and vomiting is one of the most common side effects. If you experience these symptoms, these are some things you can do to help. Eating small, frequent meals, drinking lots of fluids, and eating a bland diet can often help. If the nausea and vomiting continue, your physician can prescribe anti-nausea medication that often will help. Another common side effect is possible neurological symptoms. These include headache, dizziness, and numbness and tingling in your hands or feet. Treatment for these symptoms is typically stopping the Mitotine for 3 days. If symptoms resolve, we then restart the Mitotine at a lower dose. Because mitotane can affect normal adrenal tissue, it can cause decreased cortisol production, which can lead to a condition called adrenal insufficiency. The symptoms of adrenal insufficiency can be low blood pressure, weakness, weight loss, nausea, vomiting, or diarrhea, or skin darkening. To prevent adrenal insufficiency from occurring, patients will be started on an oral hydrocortisone tablet to help replace the cortisol your body no longer makes. In times of illness, cortisol levels increase to help a body recover from the physical stress. Patients with adrenal insufficiency do not have the ability to naturally increase cortisol levels during these times. Therefore, patients will need a stress dose to help symptoms resolve. The rule of thumb during stress dosing is to double your daily dose of steroids. As the example chart shows, you will take twice the amount of steroid dose only during the period of illness. Should you have more questions regarding this dosing schedule, please discuss with your prescribing physician. Adrenal crisis can happen when patients become severely ill, if there is a significant physical stress on the body, such as surgery or a broken bone, or if a patient cannot take oral medication, such as times during repeated vomiting. Some signs of adrenal crisis are high fever, loss of consciousness, convulsions, low sodium or low sugar, and severe vomiting and diarrhea. If you experience these symptoms, you need to go to the emergency room immediately. Many doctors are unfamiliar with mitotane. We suggest taking information about mitotane and adrenal insufficiency with you to any doctor appointment and to the emergency room. We also suggest you wear a medical ID bracelet to help alert healthcare professionals of your condition. While you are taking mitotane, your blood levels will be checked regularly to determine if you have reached therapeutic levels. Because we know mitotane can affect other organs in the body, several other tests will be checked at varied intervals. These tests include CBC, electrolytes, kidney and liver function, thyroid levels, adrenal hormones, and testosterone in males. Mitotane absorbs best when taken with high-fat food. Twice-a-day dosing is easiest for scheduling, but it is okay to take smaller doses more frequently throughout the day if you need to. Mitotane will be increased at weekly intervals once started to help achieve therapeutic levels. Listed above is an example of typical dosing schedule. Maximum dose of mitotane is 10 pills a day. Sometimes patients have a difficult time taking their mitotane pills with just fluids. Making a milkshake is one way to assure you are able to take your mitotane. Plus, the milkshake is a great way to increase your caloric intake for the day. Making the milkshake with 2% or higher milk is important because the mitotane is absorbed better with higher fat. It is important to remember to clean all the utensils you use to make the mitotane milkshake once you are done, and to use these utensils only for making the mitotane milkshake. Do not use it for other food preparation. I hope you have answered your questions regarding mitotane. Thank you for listening.
Hello, my name is Pamela Brock, and I'm a genetic counselor with The Ohio State University and the James Comprehensive Cancer Center. And I have the pleasure today to share some information regarding genetic testing for patients with adrenal cortical cancer, or ACC. I have no disclosures. The objectives I would like to get these three main questions answered in our time together. Who should have genetic testing? What does it involve? And why is it important? So for the first question, who should have genetic testing? There are national guidelines from various organizations, including the National Comprehensive Cancer Network, that recommend genetic testing be offered to all patients with ACC. Doesn't necessarily mean that all patients have to have genetic testing, but that it should be available and offered. It's important to remember that the majority of ACC is sporadic with no explanation for its occurrence. Up to 10% of patients with ACC will be found to have a genetic risk factor that contributed to the diagnosis. And that's why we offer the genetic testing to find the patients who are in that 10%. So what does genetic testing involve? It is a laboratory test that is performed on a DNA sample. We get DNA from either a blood sample or a saliva sample, and this testing is sent to one of a few kind of specialized clinical genetic testing laboratories. This testing is kind of high grade, designed to be used for medical management and confidential, different from some other types of genetic testing that are advertised online. Genetic testing for patients with ACC is typically covered by insurance. There may be copays or deductibles that may apply, but since we do have national guidelines that recommend it be offered, coverage is typically, it is typically covered. And the laboratories that perform the testing do a great job of helping to vet any possible costs up front so that there's no surprise for a patient regarding cost. The process of the testing involves analysis or assessing a given number of genes to look for any alterations or changes in them that would be a risk factor and cause an increased risk for cancer. Results are typically available in 2 to 3 weeks after a sample is sent in. And in many cases, if a patient is undergoing genetic testing, they may meet with a genetic counselor before the test to kind of collect history information, talk about risks and testing options. And then often there's a post, after the results come back, a follow-up discussion to kind of go over the results and kind of what they mean for the family. So why is genetic testing important? So in families in which we do find a risk factor, so if the test is positive, it may give us an explanation for someone's diagnosis, but it may also tell us information about future cancer risks, either for them or for their family members. Our genes are all kind of turned on and do their jobs in different parts of the body. So each gene has a unique pattern of cancers that can be associated with it. And so if we find a risk factor, then we can give much more specific information about what other risks should be on the radar. If we find a mutation in a patient with ACC, then we can do targeted testing in family members to determine who has the risk factor versus who does not. And, at that point, we know what we're looking for. It's pretty straightforward to figure out, who has the risk. And overall, the goal is to try to maximize on any opportunities for early detection, sometimes prevention that may be possible in the patient or their family members. And in some rare cases, there can be some treatment impacts, and I'll touch on that more on the next slide. If we do genetic testing and it's normal, or negative, I think that gives good reassurance to families, makes it much more likely that someone's diagnosis is in that kind of more common sporadic category. No reason to do genetic testing in other family members since we didn't find anything, and overall indicates a lower risk situation. So far, we've talked about genetic testing really in the context of what's technically called germline genetic testing, where we're looking at kind of the DNA that someone was born with, trying to figure out if there's a risk factor running in the family. Just wanted to, here at the end, kind of distinguish this type of genetic testing from genetic testing that is done actually on the tumor. Some patients with ACC will end up having both types of testing because they're both important, but answering slightly different questions. Tumor testing is more looking at the genetics of the cancer itself to figure out how to best target it or to treat it, often ordered by an oncologist. But just wanted to mention it here since it is kind of a type of genetic testing. Like I said, many patients with ACC will have them both because they're, bringing different pieces of information to the overall picture. There are resources for finding a genetic counselor. So genetic counselors are healthcare professionals that can help patients navigate the genetic testing process and provide information. Our job is to kind of try to lay out information so folks can make whatever decision they feel most comfortable with. And here is a website in which patients can search for genetic counselors in their area or available through telehealth. Thank you for your attention.
Hello, my name is Eric Miller. I'm an assistant professor in the Department of Radiation Oncology here at Ohio State. It's my pleasure to talk to you today about the role of radiation therapy in the management of adrenal cortical carcinoma. I don't have any disclosures relevant to this presentation. Here are the objectives of my talk. First, I'm going to talk about what exactly is radiation therapy. Then I'm going to talk about the role of radiation therapy really in 3 settings for adrenal cortical carcinoma. First is adjuvant treatment. Second is palliative treatment. And finally, the role of radiation in patients with limited metastatic disease. Let's talk about first about what exactly is radiation therapy. So it's a form of cancer treatment that uses high energy X-rays to kill or prevent cancer cells from growing and dividing. It's a local treatment. So we focus the treatment on where the tumor is visible on imaging or where the tumor was located prior to surgery. It's not like chemotherapy where it travels throughout the body. It's a very focal treatment and it treats focal areas in the body. For adrenal cortical carcinoma, external beam radiation therapy is most commonly used where a linear accelerator directs multiple beams of radiation through the skin focused on the tumor or the tumor bed where the tumor used to be. You can see in the picture, the patient lays on a table and the linear accelerator is the large machine above the patient and it rotates around the patient delivering the radiation. It's a non-invasive, non-painful type of procedure. No incisions, nothing like that. The role of radiation therapy is adjuvant treatment. Let's talk about that first. Adrenal cortical carcinoma is rare. We really have limited prospective data on the utility of radiation therapy in this setting. But based on the data that we do have, we consider adjuvant radiation therapy in multiple settings. First, in patients who have had an incomplete resection, where the tumor is not able to be completely surgically removed. Second is in patients who have stage 3 disease, so either a locally invasive tumor or a tumor that has positive lymph nodes associated with it. Third, patients who have tumor spillage at the time of surgery. And fourth, patients who have high-grade adrenal cortical carcinoma. This is a feature of the tumor that's revealed after the pathologist looks at the tumor, either based on surgical resection or sometimes by biopsy. While we have limited data, one of the best pieces of data that we have is a study from the University of Michigan. So this is a retrospective study. They looked at patients who were matched by age and tumor and treatment characteristics. And they compared 78 patients with 39 of them receiving radiation therapy after surgery and 39 undergoing just surgical resection alone. You can see from the figure here on the right that adjuvant radiation therapy improved multiple outcomes. So the one on the right is overall survival. So it improved 3-year overall survival from nearly 50% to 80% with adjuvant radiation therapy. There was also a benefit in local recurrence-free survival from 34% to nearly 60%. So this showed quite a large benefit from adjuvant radiation therapy following surgical resection. We would also consider radiation therapy as palliative treatment in ACC. So it can be used for palliation of large primary tumors that are either causing symptoms currently or likely to cause symptoms in the near future, such as obstruction of the inferior vena cava. You can see in this picture, this is a large tumor. It's invading the liver, and it's going to be causing IVC obstruction in the future if it isn't already causing partial obstruction now. So this is something that we would consider doing palliative treatment in the setting of this not able to be completely surgically removed. Radiation therapy is also very effective at the treatment of painful bone metastases. So radiation therapy is quite effective at helping relieve some of that pain. It's also used as a focal treatment for brain metastases. It's very effective for that as well. While surgical resection is really the mainstay of patients who have limited metastatic disease, radiation therapy also has a large role to play in patients who have limited metastatic disease. This would be a patient who may have 1 or 2 liver metastases or lung metastases or 1 bone metastasis or even metastasis to a different adrenal gland, for example. This is called stereotactic body radiation therapy or stereotactic ablative radiotherapy. So this is a highly focused, it's a conformal treatment delivered over 3 to 5 radiation sessions. It's a high dose of radiation therapy delivered per treatment. And it's non-invasive. It's a short duration of treatment with each treatment session lasting less than 30 minutes. Based on studies that we have up to this point, studies have shown that this type of treatment results in high rates of local control, so over 70%. And some of the treatment sites that we do consider for this type of treatment, like I mentioned, would be liver, lungs, bone, or even the adrenal gland. And you can see this picture on the right. This is a liver metastasis that is being treated with radiation therapy with SBRT. So in conclusion, adjuvant radiation therapy should be considered for patients who have tumors that are either incompletely removed, locally invasive tumors, those with positive lymph nodes, tumor spillage, or high-grade tumors. Radiation therapy is an effective form of palliative therapy and can be considered for patients who have large symptomatic tumors or patients who have bone or brain metastases. For patients who have limited metastatic disease, so disease that's isolated to the lungs or the liver, for example, you can use focal radiation therapy such as SBRT to ablate those lesions as an alternative to surgical resection. So thank you for the opportunity to give a brief overview of the role of radiation therapy in adrenal cortical carcinoma. I'm happy to take any questions. Thank you.
My name is Priya Dediya, and I'm an endocrine surgeon and the co-director of the Organoid Technology Program at The Ohio State University. Today, I'm going to talk about clinical trials and research in adrenocortical carcinoma, or ACC. And I'll also go over how current research focuses on personalizing treatment for adrenocortical carcinoma. I have no disclosures. In order to go over clinical trials and research in adrenocortical carcinoma, I'll introduce some definitions first. A retrospective study reviews existing data in order to determine potential effects of a particular treatment. Preclinical studies are research studies that are conducted using animals or cells grown in a dish in order to determine if a treatment is likely to be useful. Results from both of these retrospective and preclinical studies are needed to design clinical trials. There are multiple types of clinical trials. Phase 1, 2, and 3 clinical trials are needed for FDA approval of a new treatment. Phase 1 clinical trials determine safety. Phase 2 clinical trials determine efficacy, and Phase 3 clinical trials determine if the treatment is better than the current standard, and this is done by randomizing patients to the new treatment or to the current standard treatment. In order to find currently active clinical trials for adrenocortical carcinoma or for any other adrenal condition, you can visit clinicaltrials.gov and select studies that are actively recruiting. You can then enter the adrenal condition that you're interested in. Some of the active clinical trials for adrenocortical carcinoma include ADUVO-2, which randomizes adrenocortical carcinoma patients with high risk of recurrence to either treatment with mitotane alone or to treatment with mitotane as well as cisplatin and etoposide after surgery. Other clinical trials for patients with adrenocortical carcinoma include a phase 1 trial that treats patients with hypercortisolism with a drug that decreases the effect of cortisol in addition to a drug that stimulates the immune system to fight cancer cells. This trial is determining the toxicity of these drugs as well as the impact on disease progression. In this trial, patients with spread of adrenocortical carcinoma in the abdomen received chemotherapy in the abdomen at the time of surgery in order to determine how this treatment affects disease progression or complications related to surgery. Now I'm going to switch gears a little bit and talk about some of the research models that we use for adrenocortical carcinoma. Most of the models thus far have been based on mouse animal models as well as cell lines made from tumors. In the mouse models, genes that cause cancer are overexpressed or genes preventing cancers are knocked down. Some of the examples of this are overexpressing IGF-2 and Wnt together, or overexpressing Wnt and knocking down p53. Both of these models cause adrenocortical carcinoma in mice. We also use cell lines to study dysregulated pathways. Although these models have provided a lot of information, unfortunately, drugs based on these models have not worked well in clinical trials. Because of this, new research focuses on understanding dysregulated pathways in a patient's tumor by performing sequencing analysis of DNA and RNA, as well as regulators of DNA and RNA directly on a patient's tumor. Our collaborators have shown that adrenocortical carcinoma fall into 3 categories using this technique. The next step is to see if targeting the pathways that are dysregulated in each category will improve outcomes for patients in each category. In order to do this, we developed patient-derived tumor organoids from patients undergoing surgery. We minced the tumor, put tumor cells on a hydrogel matrix, and then we were able to develop and study organoids. We found that the organoids grew and produced cortisol that was similar to the patient's. For example, organoids from a patient with normal cortisol levels had lower cortisol production compared to organoids from a patient with overproduction of cortisol. We also found that organoids from the patient with lower cortisol was sensitive to traditional drugs, whereas organoids from the patient with overproduction of cortisol was not sensitive to traditional drugs. And that was the same response that the patients had. So we were really excited to see that the organoids reflect the patient response. We're now planning to use these organoids to determine which category a patient falls into and use drugs that are specific to that pathway, to that category, and the pathways that are dysregulated in that category. In summary, current clinical trials can be found on clinicaltrials.gov, and research on adrenocortical carcinoma is moving towards tailoring treatment for patients by studying RNA and DNA characteristics of the tumor, as well as making organoid models of the tumor. Thank you very much.
My name is Denise Schimming, and I'm here today to talk about supportive care services for the adrenocortical carcinoma population. I have no disclosures, and really the objectives of this discussion are to define palliative care, define survivorship, and to define hospice, along with provide resources for these three. To start off, palliative care is to palliate, is to make a disease or its symptoms less severe or unpleasant without removing the cause. Palliative care generally is provided within the context of serious illnesses, such as cancer. And really what it focuses on is comfort care, pain relief, and symptom management. Palliative care is appropriate at any age and any stage of cancer, and it can be provided along with curative treatment. It supports patients' physical, emotional, and psychosocial needs, providing comfort and improving quality of life for the patient and the caregiver. Hospice is a type of medical care that gives seriously ill patients and their loved ones meaningful time together when the focus of care turns from active treatment to comfort and quality of life near the end of life. Hospice is not a place, rather it's a full range of services that put patients and families in control, giving them hope about their last days, weeks, and months together. Hospice really supports people near the end of life by focusing on each patient's goals and their wishes. They can help a lot with managing symptoms such as pain and other side effects related to their treatment. They also can really improve quality of life. And once a patient is deemed eligible for hospice by their care team, their transition can start as soon as they agree to transition. Some important facts about hospice care is that hospice is for people with advanced illnesses such as cancer. And like I mentioned earlier, it does provide symptom and pain management for patients with those illnesses. Hospice can really happen anywhere, and it's a choice. It's a choice that can be deemed with the patient themselves and the care team. Hospice can give medications as needed to help with symptoms, and it can help keep track of medications while on hospice. There's really no limit to the time a patient can be on hospice. The rule of thumb is that it's for patients who have 6 or months left to live, but this can be extended at any point in time, and it can also be revoked at any point in time if the family feels that's necessary. The next thing I kind of wanted to talk about is what is cancer survivorship. Well, cancer survivorship begins at diagnosis of cancer and can continue throughout a person's lifetime. Cancer can affect people in multiple ways, physically, emotionally, mentally, financially, and it can also really affect families and their relationships. Each needs are very unique to the patient, and the needs can be different based on the type of cancer you have as well. The main point with cancer survivorship is that there are many different types of survivorship, many different terms for survivorship. I've heard a lot of patients in my visits refer to themselves as thrivers, survivors, warriors, just to name a few. And the needs can be very different for the cancer patient as well. The needs that they need during treatment, after treatment, at initial diagnosis through the end of life can kind of wax and wane and change as time goes on. So I have some patients where I can meet the beginning of diagnosis and have certain needs, and then at the end it's completely shifted, where we talk more about healthy lifestyle and things that we can do to reduce risk of cancer reoccurrence. But really, the clinical goal of cancer survivorship is to help you manage the issues that arise in order to improve your overall well-being. The last couple slides really are just resources to help you and your family get through the diagnosis. Here at the James, we do have the James Palliative Care Clinic, and it is an ambulatory referral to palliative medicine that can be placed by your care team. And I also left here a couple resources for hospice. Specifically, the National Hospice and Palliative Care Organization is a website that just has a wealth of knowledge and information for patients and families. One of the big things I like about this website is that it gives you the ability to search for local providers. So if I have a patient that doesn't live here, in Columbus, where can they go and what resources? I'll sometimes look at this website. So again, it's the National Hospice and Palliative Care Organization. Some resources for the Cancer Support Clinic. We specifically have a survivorship clinic. That's where I work. And you can self-refer at any point in time. So the patient can just call the 614-366-8700 number, or you can schedule through MyChart, or you can have your provider put the referral in. And then a couple others are the cancer.osu.edu, cancersupport.org, and then the Cancer Care one. And specifically, I use that one a lot because it provides a lot of free professional support. Some of the services that they include are counseling, support groups, workshops, and financial assistance. And they are provided by a social worker a lot, or a psychosocial oncologist. And the website's listed there, www.cancercare.org or 800-813-HOPE. Finally, there are some resources for workplace issues or insurance. Specifically, we use findhelp.org. It was formerly Aunt Bertha. And the good thing about this is you can type in the zip code to find any potential assistance in your area. I really appreciate the opportunity to discuss the supportive care services for the adrenal cortical carcinoma patients and their caregivers. And please reach out to me if you have any questions. Thank you.
We hope you found this series of lectures helpful. Please feel free to use the list of resources you see on the screen, consider supporting adrenal cancer research, and participating in one of our ongoing surveys.